Well, hello, welcome again to another Move It or Lose It. So today we're very excited. We've got Dr. Mikhail Kogan, and hopefully I said his name right. He'll hopefully correct me if I'm wrong. So very excited today. So he's written a book that I've been really listening to. I can't read it, so I'm so excited when I was able to find it on audio. So it is medical marijuana. And it is a book that I have really enjoyed listening to the combinations of how we can use cannabis for so many things, not just for me, for multiple sclerosis, for spasticity, and being able to use topical, but being able to use different things that not just being able to smoke it, but being able to use it for different terpenes and things like that. So no further ado, I'm going to now introduce Dr. Kogan, being able to explain the book and how it is used for different things and different ways that we can use it. So I love that. Why don't you talk about born in Moscow and moving to Israel and then to the US, and go ahead and explain your story and from there and how you got here.
Yeah, it's definitely not a usual story. And more importantly, I think it's very surprising that I end up specializing or subspecializing in this particular field because, anybody growing up in Russia, cannabis is the last thing you ever would think to have any kind of therapeutic benefit. In fact, the typical brainwashing in probably entire former Soviet Union was that you smoke pot once and then your life is done. You're going to go to heavy drugs, prostitution, gambling, and premature death. I mean, that's what we all learned. The whole level of lying in Russia was not any better than it was in America back in the US back 30, 40 years ago. I mean, this whole field of sort of somehow saying that cannabis is an addictive and dangerous drug is just so hypocritical and such a big lie. Like it's not even clear. It's not a conspiracy theory. It's just it was all in open. Nobody was hiding it. They were lying about. I mean, it was all nonsense. So, but this is my inheritance. This is how I grew up. So until I actually way after medical school, which I did in the States, and I started specializing in geriatrics, until around 2012, I was completely clueless about this whole topic. Like I just, to me, it was addiction only kind of field. But in 2010, where I practice in Washington, D.C., the cannabis was legalized for medical reasons. And pretty much quickly after that, a lot of my patients start saying, hey, somebody said this and that. And I'm like, okay. And, first I was ignoring most of those patients, but eventually sometime in 2013, I met Donald Abrams. We were serving as a founding members of the American Board of Integrative Medicine. And I think we had so many conversations, and, he's like an outmost research expert on this topic. And at some point he basically I think, told me in the face, like, dude, you got to catch up with the evidence. And because you're serving geriatric population, there is no better drug. And he was the first person who said, look, and so once I start learning and I start realizing, wait a second, he's got such a good point. I mean, it's one of the most broadly impactful medication that I can prescribe to anybody. I mean,
and one of the oldest.
And one of the oldest, of course. If I kind of think about a complex patient with 5, 6, 10, 15, 20, 30 different medical problems, if I have to treat them with different medications, different approaches, I'll have to prescribe them a whole slew of stuff. And here I can just give them cannabis and half of everything they have: nausea, anxiety, insomnia, pain, dry skin, eczema, the constipation, diarrhea, irritable bowel syndrome. I mean, we can go on and on and on. And I can just try one product that's safety-wise safer than Tylenol and Motrin or anything else I can prescribe for that matter. There's no safer prescription that I can give an older adult than cannabis when it's done right. So I think that led me to a very simple kind of process, because I just started doing it, and I think one of
that was your first book, Dr. Kogan? Was that your first book, The Geriatric?
No, I wrote a couple other books
Okay,
before. So I
okay,
have a book, I have a textbook in Integrative Geriatrics, which is
okay,
what I specialize. I don't really call myself a healthy aging expert. It's a little different. Like I'm not, uh, my specialty taking care of older and
mhm,
complex ill patients. And I think my main kind of subspecialization, if you will, is how to get people off of multiple medications.
right,
That's what I do
yes,
day after day. And that's where
right,
cannabis shines. I mean,
right,
people would come to me with opioids and benzodiazepines, and I'll have them off of
right,
everything in 3 months.
right,
And I think that's the impact here is that I'm saving this, what we describe or what we call an iatrogenic complication. So
right,
basically prescribing less drugs leads to just better
for
longevity,
sure,
longer outcomes. So I think I'm not in the field of longevity, but I am in a way that by default I'm making my patients healthier, and thus they probably live longer. And then there's also a book that I co-wrote with some of my collaborators on integrative geriatric nutrition.
mhm,
And now next year my optimal aging book with Andrew Weil is coming out. So
okay, okay,
so
very good,
that's been my yeah, it turned out I'm a dyslexic, so I can't really write anything. My spelling is no good.
yes, yes,
I got born in the right time because before
okay.
computers, forget it. But
See,
but
I
I
can't do that just because of the MS. It's just, I can't put it together. I could do a podcast and I can do all of that, but when it comes to writing, it's just a big run-on sentence. So it's not there.
yeah,
So,
I see. Yeah. Well, that's that's well trying to make the best of it, right?
right, for sure.
I'm
S-
I'm actually very impressed. I'm very impressed that you're doing this
Oh,
despite
thank
the
you.
limitations. I think a lot of
Yeah.
you're empowering a lot of people.
Thank you. I think it's just so important that we bring this out in the open because I think there's still, a concern, there's a fear. I think that, and I'm asking from your point of view, do you feel that in the last few years, do you feel that people are more and more open? And do you think the age ranges from younger to older?
Yeah,
What do you
yeah,
see?
I think so. I think you're absolutely right. I think we're seeing a very rapid uptick in use in older adults specifically. I think there's more and more awareness of dangers of drugs. I
Mhm.
think about 2022. So I think about 6 years ago, medications moved from the fourth leading cause of death in America to the third, and we're on the
Mhm.
track to have drugs to be a second leading cause of death,
Right.
and in 50 years to the first leading cause of death. So
Yes.
our healthcare system will be killing more people than cancer and
Right.
heart disease. So,
Yeah.
we're on the track to we're already killing 250,000 people every year
Yeah.
just by the way we do business. So I
Yes.
think a majority of those patients are over 65 just because
Yeah.
where the side effects are much more common. So I think
Yeah.
just awareness of this fact drives a lot of the people into safer alternatives. And I
Mhm.
think there's a couple of years ago, there was a New York Times article saying that literally older people flocking to the cannabis as a panacea
Yeah.
to pretty much everything. I think there is some degree of hype, of course,
Right.
because the industry itself is new, maturing, and
Yeah.
doesn't really know how to kind of regulate itself well. There's a
Sure.
lot of really bad players. There's also a lot
Sure.
of commercial interests, the way that the pharmaceutical companies do it, and I think there's also a lot of hesitation because of that on the side of true academic experts. But
Do you think it depends also on what state you live in? Like, let's say, like I went to go visit my best friend that lives in Colorado. I love going when I go there because I feel like I can go into a place that is somewhere that they like, and I get so much information that I can't get here in Michigan
right.
because we're so far behind.
Well,
And I
actually,
get,
you're Michigan, not necessarily. I can refer you. I have a sister company in Michigan
oh,
that's
good. Okay,
very
great.
advanced, very
Very
advanced.
good.
So no, I think there are pockets. So it
Okay.
actually doesn't necessarily matter at what point what state approved what. The difference is in dispensaries. So like
Yeah,
the older dispensaries gradually over time become more and more medical. So like
right,
I'm a good witness of this because we in tri-state, I'm licensed in the entire DMV area, district, Maryland and Virginia, and I see how they differ. And there's a
right,
pretty big difference. But the reality is, no, like everybody knows this and everybody closes eyes to
right,
this. People just go where they need to get stuff.
right,
And now most of the states have a formal reciprocity, so you can take your card and go to another state and buy it there. Now,
right,
you're going to cross the state lines, that's illegal, but nobody's going to
exactly.
stop you
Yeah,
unless you're a person of color or
right,
and then like there's still a lot of segregation and
sure.
racism in this field,
Oh,
unfortunately.
absolutely,
I was just
absolutely.
I was just part of the DFCR, Doctors for Cannabis Regulations panel on Brittany Griner case in Russia and also what's going on in America. We still have a lot of prejudice. So the
Yes,
topic is, I think it's like diehards, older generation of people who
yes,
are clueless.
yeah,
They never bothered to learn anything. And for them, the
right,
topic. I recently talked to I'm not going to say the name, but like a really high-end expert in palliative care. And she's like, oh, CBD is all placebo. And I was like, oh my God, like you didn't even bother to look at like
right,
2017 NAS report,
right,
kind of data. You just like, you don't want to learn because you think you're the expert.
right,
And there's a lot of that going on. I think, but
yeah,
that's fine. I mean, all that old generation will die out, and
right,
the information, science, the way Ethan Russos put it, I think is the best. The cannabis is going to follow a traditional scientific path. It
right,
already is. It's following it.
absolutely,
As
absolutely,
evidence accumulates, we're going to see
right,
consolidations. We're going to see what it's good for, what it's not so good for. There's a lot of fascinating questions, like the CBD question. Does it really truly work for pain? Nobody knows.
right,
In terms
right,
of evidence-based, we don't know if it's all placebo or
hmm,
does it have other impacts?
right.
It
I mean,
does.
I use it for my spasticity, and I use, and what I did, I think that I read this in, or my Audible, I can't really read with my eyes, but, in the Audible about, so I will take the Mary CBD, and
Mhm.
then I will take, the THC, the Rick Simpson, with that's just the THC. And I will put it, I will, heat up the Marys, and then I will put a little bit of THC in, and I'll try it, see if I get any relief. And then I'll add more if I need to. So I'll just kind of go with it. I won't add a bunch in there. I'll just kind of go with it. And then I'll start to rub it into the muscles that are spastic. And I'll just kind of go with that through the day. So that's how I kind of gauge it. So I don't add a ton in there. I
Right.
just kind of gauge it through the first couple days.
Well, I mean, the CBD is a fascinating compound, right? It interacts with our own endogenous THC, quote unquote, right? So anandamide and 2-AG. It doesn't actually affect the receptors very strongly or at all for that matter, but there's modification of the endocannabinoid system and modification of THC. So I think most of us who've done enough work here know that pretty much everything you do has to be a mix of some sort.
Mhm.
Whether it's whether there are THCs in the mix is secondary often, by the way. So THC is not
Mhm.
always the answer, as you said.
Right.
But the pure THC, yeah, sure, it's going to work, but you can add some CBD to it, and you're probably going to potentiate some THC effects.
Mhm.
Maybe exception is the pain. It's actually not very clear. Certain types of pain, you add CBD to THC, you may actually decrease efficacy of THC. So there's a lot of unanswered questions. I think there's also a lot of lack of clarity, like in terms of seizures and in terms of
Right.
anxiety and hyperexcitation, neurological symptoms of progressive neurocognitive decline, when people start getting neuropsychological disturbances, especially in cases of advanced Alzheimer's or Parkinson's disease. CBD is a godsend. I mean, I've had people who were about to be threatened to be kicked out from the nursing home or some group home just to completely turn them around within a few weeks. And and really have their last years are, in much better shape. I actually will
Interesting.
tell you, in my opinion, cannabis is the best palliative drug we have. We don't
And
have
you're talking
any
just
better medication.
CBD.
No, all
Okay.
of them. I'm talking
Okay.
about cannabinoids as
Okay.
I would say, endocannabinoid or exogenous cannabinoid modifications of any end of life conditions.
Right.
And frankly, in my experience, it's one of the most versatile and probably the best palliative drugs. Between
Yes.
opioids and
Right.
cannabinoids, you can
Right.
probably manage almost any end of life condition. And I'm not afraid of saying this because that's what
Right.
I
So talk to me about that. So talk to me about, we've got a patient, like we've got a multiple sclerosis patient. And they're, that's one of the things that we're prescribed immediately. Opioids, we're still prescribed that. So we want to get off that. We want to not be on that. So we've got that pain.
Well,
And
let's
so,
first talk about why people should be getting off of opioids and why it is so important, right? So
right,
I think this is a very heavily misunderstood situation. When we give someone a replacement for our own endogenous anything, there are two things that could happen. One, you will dysregulate natural production. Second, you could simply, even if you don't dysregulate that production, the amount of particular tone in that area, like endocannabinoid tone or endorphin or in the endogenous opioid tone, could become too high and risky. So it turned out that the cannabis is the only internal system that the risk of overdosing of the tone is very small because you have no receptors in the brainstem. You'll never suppress your respiratory drive because there's nothing to suppress. There's simply no receptors to impact our respiratory drive. In contrast to morphine, I mean, your threshold before you're actually going to kill someone with morphine is, you can't even compare. Like there is no, we don't even know what the lethal dose of cannabis actually is. It's not practical to ingest that amount to try to kill someone. It's been done in the 60s and 70s. They tried to kill the monkey with cannabis. They had to give it 800 cigarettes to smoke. And it's died in a plexiglass cage. Turned out didn't die from cannabis, just did die from a carbon monoxide poisoning. We have no idea what the actual lethal dose of THC is. I mean, we could experiment with this, but again, as I said, it's not practical. With opioids, that's an easy formula.
right.
You have a little too much and then you have a problem. So this is the issue. So why
So
that
when you
is?
talk about the CBDs and so when we talk about those things and we're talking about taking the place of the opioids, talk to me about the different, because a lot of people don't know that. They go into, they purchase something, they don't know what is a CBN, what's a CBG. They just think, okay, so it's a CBD.
What happens a lot is they would read an article, describes new as the greatest, the best, and they're going to go try it. And that's a very wrong approach. Unfortunately, the endocannabinoid system is a highly tuned structure. And tweaking it and playing around with this actually takes a lot of expertise. And yes, you can do it on your own, very slowly, patiently, and carefully. But I will tell you from pragmatic personal experience with patients, most people cannot do that.
Right.
They either take too much or they take too little. They stopped too early or they continue something too long and it doesn't do anything. So like, it's really that. So, and I also don't necessarily like to say, okay, CBD take for this, CBG take for that.
Right.
The problem with this logic, yes, you can say, okay, CBG is really good for neuropathic pain and for as an appetite stimulant and also as a kind of a booster of energy in somebody who's really frail. Yeah, that's a general statement, but I'm not going to give somebody just CBG for that. I wouldn't expect it to be much of anything because I'm going to do tons of other things in parallel because that's the beauty. We completely misjudge how the endocannabinoid system operates. It's not sitting there in an isolation of container. It's constantly interacting with the rest of the body, and the pathways of interaction and the complexity of it all is highly sophisticated, and that's how it needs to be approached. Let me give you an example. Everybody is gung-ho about the acidic forms, right? So the CBDA,
Right.
CBGA, THCA. Sure, I mean, I use CBDA for patients instead of NSAIDs and instead of even steroids for rheumatoid
Right.
arthritis in a very high dose. But I'll never probably use it alone for a particular reason that actually, in my experience, it's just not enough. And so, but then you add a touch of THC in there and suddenly you see a massive shift.
Right.
But
So for something like me, I have multiple sclerosis, so I can't take a medication for my rheumatoid. So the two don't go together. So I would have to rely on something like that. Now, I've never even thought about that. That's
Right.
never even been something I thought of, that I can do cannabinoids or cannabis for rheumatoid.
Oh,
I never thought
at
about
this
that.
point, I have like countless patients who got off all kinds of rheumatoid arthritis and lupus drugs because, the cannabis often ends up being a missing link. Like we would
Mhm.
have those patients on a highly sophisticated anti-inflammatory approach, you know,
Right,
a paleo or autoimmune diet, or at least
right,
inflammatory fatty acids, high dose, turmeric, high
right,
dose, all kinds of things, saffron and all. And they'll get a little bit better. But then you start tweaking the endocannabinoid system over a course of, say, 3 to 6 months. And that's where
right.
miracles occur, because
Sure.
the endocannabinoid system, in a way, is one of the biggest checkpoints of inflammatory response. And a lot of people, even within the integrative medicine world, don't know this. And they keep
Mhm.
applying standard anti-inflammatory principles, forgetting that actually at the end of the day, endocannabinoid system regulates inflammation as one of the primary aspects. This is the critical part. The trauma and stress response regulation start within the cannabinoid system, and frankly,
Right,
probably end there. But most of our inflammatory responses, unless you have a sepsis in a hospital, are actually heavily linked to the chronic stressors. And that's where
Mhm.
why do you think all the veterans flocking to cannabis? Because they
Right.
on their own figured out that it's the best treatment for PTSD that
Yeah,
you can have. There is
very
nothing better.
interesting,
There is,
very
there is,
important.
I mean, they can go do complex treatments with yoga, with counseling, but VA doesn't necessarily, or well, not every branch will offer that.
Right,
It's complicated. It requires a whole system in place. Sometimes you have to pay extra money for it. It's just so much easier to smoke a joint.
right,
And
right.
I don't necessarily agree with that, because I think the more holistic approach ultimately is almost always better. But I have to honor what they're doing because they know it's
Sure,
making me feel better.
sure, sure. So in your practice, yeah, I know that you talked about, I've heard you talk about smoking isn't ultimately your first choice, but especially through COVID and all of that. But if someone is doing that and that's what they've always done, you'll honor that.
Of course,
So for you, your first choice would be, what would you give for your first choice?
I mean, I think RSO is a great choice. RSO is highly versatile because you can mix it into anything, and you can
Mhm.
make your own tinctures with it. You can make the
Yeah,
topicals with it, suppositories. It's perfect for that. So, I mean, if you're playing with this, I think RSO is also
right.
quite much lower cost per
Yeah,
milligram than anything.
yeah,
So, that's the biggest advantage. I think the sublinguals are usually my first choice for almost everybody. There are two main reasons for that. So one, you can still, if you're trying to do something for pain, for anxiety, for depression, for insomnia, for anything that's involved central nervous system, I think sublingual route is very relatively quick and very predictable. The problem with edibles, for example, I mean, there's a lot of variations that go into using edibles, what you ate
sure.
before, how your liver status is. I mean, you could have some alcohol and then to completely different effect altogether. And so it's less predictable. That's one thing.
Okay,
And I think the other thing is practical, right? So the issue with smoking Well, first of all, what if the patient is in a structured environment, like a group home or nursing home? Well,
Mhm.
you can't really smoke there. I mean, you can. I had a 95-year-old patient. I followed her for about 15 years before she passed at 95 or 96. And like, she finally ended up in a nursing home in her last days and weeks. And she was like, hell no, I'm not giving up my cannabis. That's what kept me alive for
Right, right,
so like we had quite a conversation with nursing home director, and I
right,
basically told him up front, dude, you don't let this woman smoke on the porch. She knows every Washington Post journalist. You
right.
trust me, you don't want this shit on your hand. And he's like,
No.
okay, forget it. We're gonna have somebody escort her so there's no one else and let her smoke.
Oh, that's funny.
And so
I love
you
it.
can get around anything. That's the bottom line.
Sure.
So the system is
Absolutely.
structured, but inhaled form is really rapid onset and relatively short-lived. So it
Right,
has its own, if you think about this, every route has its own advantage and disadvantage. And that's why this is so sophisticated. It's not just
right.
its cannabinoids, it's also the terpenes, which we should talk about. And then also the routes. There's so many intricacies here that, like, for example, one of my favorite routes is rectal.
Yeah,
You can have massive doses of THC if the person has any kind of a pelvic floor dysfunction, back pain, any inflammation like an ulcerative colitis, prostate cancer, prostatitis. I mean, you can have a massive impact on all of these conditions with the rectal suppositories.
what other things for the rectal suppository? What other things
Those are
beneficial for
those are the
rheumatoid
main.
or MS or things like that?
Not really. I mean, there is a controversy whether rectal actually is systemically well absorbed. I'm not sure. I will tell you, I think for that to occur, you have to have a very high doses and it becomes simply cost prohibitive. But it's a very powerful local treatment.
Mhm.
Like I will tell you, if the woman comes to me and says, I have a pelvic floor problem, like a
Right,
pelvic pain, I'm
mhm,
not going to talk about anything oral. I'm going to talk
right,
about acupuncture. I'm going to talk
mhm.
about special pelvic manipulation, like myofascial releases, and sending her to one of my physical therapist referrals. And then I'll give her suppositories, vaginal
Okay,
or rectal. And I would
okay,
figure out what ratios to give, like, right? So if the woman has a spasm and pain, it's going to be a bit more THC. But if it's an inflammatory state, it's probably going to be a triple, like CBDA, CBD, and THC in a balanced form.
very
So,
interesting.
so that's the way to think. Uh,
Right, right.
but the let's say you
See,
want.
this would be so new to people. I think so many don't think about cannabis in this way at all. They think about it in, I mean, people go to Walgreens and get this, and that's terrifying.
They get
That's
CBD
scary.
programs. And I find it ironic because if you kind of think about how all these large organizations, what they were saying 20 years ago about all this, they were like, this is all scam. And now everybody's cashing in.
Right.
It's a typical American,
Oh,
you know,
yeah.
like we'll do everything wrong until finally we will adapt it because we're making money.
Right.
Like,
Right. For sure. Definitely. Everybody's making it now. So it
well,
is,
it,
it's crazy.
it is crazy and but it's going to level off.
Yeah.
I think we're seeing evidence accumulating. I think we're seeing gradual but steady support for research. It's moving in
Yeah.
the right direction. I'm
Yeah. I
involved.
was going to ask you that. Are you feeling like where you're finally getting more support to do more studies?
We are. Like I had a $500,000 grant in my own institution, and it was interesting because I got it from industry, and it went all the way to the leadership, and leadership said, "No, sorry, this institution is not ready for studies on cannabis." So there's still resistance, but then there's a lot of institutions where they really like doing research on this because
Right.
it's their income. So
Sure.
on the national level, especially at levels of NIH, there is a steady move. I mean, we're moving gradually, not just in bench research, but also in the clinical studies and preclinical studies. So there's definitely
Okay.
a movement. I think the general sense in science is a kind of a now cautious optimism, I would say.
Mhm.
So it's gradually moving forward. I think we are beginning to enter cannabis revolution in research,
Mhm.
because there's going to be a massive shift in a lot of research infrastructures. The moment it will become obvious that cannabis is going to replace almost all of the opioids in upcoming decade in terms of the frequency of use. I mean, opiates not going to go anywhere.
Right.
But in terms of the percent utilization for different pain syndromes, cannabis is going to replace probably 75% of all the opioids in upcoming decades. But that will require a steady, gradual process, and the research that's going to pinpoint particular protocols. So right now, like, okay, well, THC is clearly effective for pain. There's not a lot of argument about this. But
Right.
should you add some CBD, or should you add some CBDA, or should you,
Right.
for neuropathic pain, combine THC with CBG? And there is no research answers to this. It's all in the hands of, just expert clinicians who are
Right.
experimenting, and it's like you're seeing one story and you're like, oh my God. Like, I had a guy maybe about 10 years ago, early on, maybe 8 years ago, pretty early on. And he was at the Mayo Clinic, Cleveland Clinic. I remember somebody told him about me, and he has this horrible night terrors. The guy for 30 years was not sleeping more than 3 or 4 hours a night. And he was on every existing, and he has bipolar. So he has every existing medication. He is on every like antipsychotics known. He rolled in, he had someone to help him to roll in 4 suitcases of records when I first saw him. Of course, I didn't see even a fraction of it. I mean, because there were like thousands of pages of records.
Wow.
I mean, he had like more sleep tests than you can imagine. And, and nothing was helping him. Within 4 weeks, he was sleeping normally with a tiny dose of THC, upwards of about 5 to 6 milligrams.
One of my best friends has, she's done all these studies, and she's had night terrors for years. Wakes her husband up every night with these night terrors.
Yeah, and so like I did this is early case, and I'm like, oh my God, like, is this for real? And cases like this, they just stay with you, right? And then you move on and you learn, and in essence, of course, there is no research on night terrors and cannabis.
Right.
I mean, there is just none. But people like this, they trying stuff out of desperation. And unfortunately, I still call medical cannabis field of desperation, because it often happens this way, right? Which is very unfortunate, because if this guy would have tried it years ago, before all this stuff happened to him, I mean, even though we know,
I mean, that's where I feel like I was. It was like I remember looking in my drawer and looking at the hydrocodone and looking at the sleep stuff, and I just finally looked at my husband and said, no more, I can't do this. And back then, I mean, this is 6 years ago now, it was literally going to places that were really shady, and just, I mean, I'd never smoked before. I'd never done anything before. And so it was me trying to piece together what could work.
That's the problem. You shouldn't be piecing it together. You should have an easy access to an expert who's going to tell you this is what you're going to do. And it's not even the issue of ethical. It's not just an ethical issue. It's the issue of safety in many ways. The ethical issue that if you think there is something effective, our population should have access to it, right? And we should have access to experts to guide them on, and we don't have that on the system level.
I could not find anyone like that that I could have access to.
The issue is bigger. The issue is safety. And currently, the biggest problem with cannabis is not even the lack of understanding of what's what. We can experiment with that and get right combinations eventually. It's the problem of the access to quality products, because people are coming to us with like stuff that they've tried. And I mean, now with Delta 8, that is like the basically a public hazard right in front of our eyes, and nobody's talking about it. Like everybody talks about opioid overdose, but the fact that 100% of Delta 8 products are contaminated with heavy metals and whatnot. I already saw probably 4 patients with heavy metal toxicity from smoking delta
Very
8.
scary.
And
Yeah,
one guy probably gonna die from it,
very
because
scary.
he developed this complex complications, and nobody knows what to do with him now. And it's pretty obvious that it's delta 8. So,
I could
you know,
see that because when it first became, open here, they were only in neighborhoods that were really, not nice neighborhoods at all that we had to drive to. And it was, it was nerve wracking to go in. And it was, you had to ask questions, but the people that were working there, didn't know anything. And it was scary to go in. And so to make those changes, it was just, me trying to figure things out, doing a lot of reading. And it was, it was like some things were just a big mess, and I'd wake up like stoned and way too much. And then other nights it was too little and I'd be up all night. And
but
so
I
it was,
wanna not just highlight, but commend you for one thing. You stuck with this.
yeah,
And you decided to go through and keep trying. That is what should happen. And if I were to get one message to all your listeners, if you're gonna try it, and let's say you can't afford guidance, you can't afford like a coach because they charge,
right,
you only have access to something, like you don't have
right,
access to buy whatever. Stick with it, because yes,
right,
you're gonna overdose, you're gonna underdose, but the beauty here is you'll wake up the next day and the overdose will go away,
right,
and eventually you'll get there. I
right,
think unfortunately a lot of people don't understand that, and they're just, oh, I'm overdosed, I'm done with this, and
right,
they're not realizing that, okay, they just had a side effect because they're not doing it right.
correct,
And that is the repetitive theme, and the problem is that industry is too slow to self-adapt. They're not
correct,
self-regulating to say, okay, how do we improve patient experience? They're trying
right,
to improve patient high experience because
yes,
in their position, somehow that makes a lot of money. I'm not going to argue over recreational aspect. That's not what I do. But like for medical aspect, there has to be the same. The
yes,
dispensary, they should be responsible for training their staff adequately to say, okay, this is what we're gonna. Most states do not have that level of sophistication.
right.
Some are beginning. By the way, Michigan is one of those states.
They do, I still feel like I am training them. I'm training them with your book, and I'm training them with,
Where are you in
with,
Michigan?
I'm in, the Detroit area. So I'm a suburb
Yeah,
out of Detroit.
yeah.
So,
Chicago
there's,
has a lot of good stuff.
oh yeah,
Chicago is
yeah, we were in Chicago and they did. And, so the one that I go to that I do like, that is near me, does have a separate, so we are separated. So it's, it's not one of the ones that you go into and you're all together. And it's like, I'm with all the rec people and it's a party time. And I'm like, what, I'm teaching them things. So the one that I really like, the closest one is, they do at least put you on the medical side. And I do feel like I'm teaching them regardless. Everything when it comes to what I do with the RSO and how I like it 1-to-1, and how I fill them up with, the empty, pills that are the empty pill, the capsules at, through Amazon. And I use that. So, and they're like, you do what? And I'm like, yes, you should know this. And so it's just,
in more advanced states, I think the dispensaries and the producers that are fully integrated and who actually listen to their patients, like in the Maryland, where I am, one of the Liberty and Connecticut is their medical branch. That's what they do. I mean, they listen to patients and they say, okay, RSO capsules, right on, here it is.
right,
Like that's what should happen. I mean, there should be
right,
a continuous back and forth between all the parties, because actually at the end of the day, this is gonna mushroom into like its own field, because like think about it,
sure,
right? Amount of variations between different strains and different, well, strains is variants, and also different ratios of cannabinoids
right,
and the terpenes and everything is basically infinite,
Right.
And then on top of that, all these routes of delivery, and now you end up with like, oh my God, I mean, sky's the limit. And actually,
Right.
so, and what I think in the long run, we're going to see for patients who are going to find this effective and they're going to try it and they're not going to be afraid of experimenting in the
Right.
expense, because unfortunately there is an expense and most of the
Sure.
time it's not covered.
And that is scary because, you know, it's easier to say, okay, I don't want to be on these opioids, but my insurance covers it.
Right.
Where you look to the CBD and with the THC, and it's, you know, when I was playing around with stuff, it would be $200 a week sometimes. And so that was, you know, that was a really scary amount. So,
But
you
what
know,
I
it
think
is,
eventually will occur, the prices will normalize down.
yes,
But more importantly, I think we're going to start entering a phase where you should be able to go to your dispensary or whatever that's called
right,
and say, this is what I need. And they'll say, we will make you your own product. So
yes,
there's going to be a way to make compounded products that are specific for a given individual.
yes,
Because right now it's like, well, we don't have that. Like
yes,
the suppositories is a great example. Okay, some more medical dispensaries in our area that have been around for a long time, they have all
okay,
kinds of dispensaries. They'll have 4,
yeah,
5, 6 choices. But most of the states, they don't even know. Like I've had a situation where I sent a patient in West Virginia to a dispensary, and I'm not licensed there, so she had to get a card. And I said, okay, go get this suppository. And when she walked into the dispensary, they said, suppositories, there's no such thing. I'm like, what? You guys,
right,
so, you know, there's, as you pointed out, often patients teach the dispensaries, and
right,
that's not just ironic, that's insane, right? Because
right,
they're supposed to be the experts in this.
right,
And often
for
they're
sure.
how to make people.
And I think too, like, I love what you talked about. Like it's funny because I have 3 adult children. And so they think it's hilarious. Like, you should ask my mom. She knows everything. Like, you know, my mom, who I never thought would smoke pot, she knows everything about marijuana. So they send their
It's
friends
usually
to me.
the opposite.
Right.
It's usually the opposite. Parents of our age, I'm not going to guess your age, but whatever. And
Yeah,
so usually it's the opposite. It's the teenage
right.
kids that are teaching parents. And
Exactly.
I
No,
actually,
they find it hilarious.
it's a lot of funny stories. Sometimes they're a little scary
Oh, yeah.
all of our kids are
Oh,
young
yeah.
teenagers, and I get frantic calls in the middle of the night saying, "Oh my
Oh,
God,
yeah.
God, they did this, and this is what's happening."
Oh,
I'm like, just go to bed.
oh, and
Find-
between us, we've got 5. So my husband, I remarried in 2019. So between us, we have got 5. So he's got 2 adult children older than mine. So they just think it's hysterically funny because pastor's wife turned now, like they'll say pastor's wife turned like drug dealer. And I'm like, okay, stop it. But it is funny that that I do know so much about it, but I've had to do so much research, as I've said, because there was nothing here. And so I just have read, and my husband and I have read so much. And so, and he actually does a lot of security he does AV. So he does a lot of security for different dispensaries. So it's made us both just very well read on the different cannabinoids and stuff.
But
But
this topic of kids is actually quite important. I wanted just to say a word about it. I mean, I'm thinking of writing a book about this because, you know, they're not going to stop using it, but they need to
Right.
understand. And often, you know, because they end up in the recreational, for most part, nobody's talking to them about trying to
Right.
use some CBD and at least to try to balance off the negatives
Right.
of THC.
Well, the anxiety is, like, you know, with that age is off the charts. And they
Right,
don't
and I
know
mean,
what to
they're
do for it.
self-medicating. Those who try to do it medically, they're often self-medicating if they're not
Right.
getting just high. But, you know, they're not really, nobody teaches them, look, yeah, you shouldn't be doing this, but okay, if you're doing it and you're
Right.
not going to give up, at least start minimizing the harm by eating CBD.
Right.
Try to not smoke if you can. So, you know, like a common sense things are easy to argue for. And if you approach it from, no, you're not a bad person, but
Right.
very adult conversation. I actually, sat down with my boys, and then when a bunch of their friends were at our cabin, and I set them down and I said, we're going to talk cannabis, and they're like giggling, and I said, no, you don't understand. We're going to talk cannabis. You're going to tell me like questions you have. I'm going to answer whatever, because I'm the good person for you to ask. And
Right.
actually, it was a very long, like an hour-long conversation. I put it on my YouTube because I felt like the parents have responsibility to talk to kids about this. And yes, quite often it's scary because often kids know more than parents do. But at the same time, if the parents start learning and understanding, they will be able to get themselves on the same level with kids and actually have an adult conversation versus like, oh no, you shouldn't be smoking. And that's it. Like, you think that's going to work? Good luck. And that's actually an important topic, because as more and more states going to legalize, we're going to see a rapid uptick. We are seeing rapid uptick in kids and teenagers using more. And the problem is, definitely there is going to be more accidents, but okay, so maybe not necessarily a lot more deaths from accidents, but there are going to be more accidents, and the brain development is we're going to start seeing impact of that over the next decades. So I think doing more research in this and figuring out, we're not going to impact them using it, but what should they be using? Should they be using 10-to-1 CBD to THC? Okay, they may not like it, they may not get high enough from that. Okay, so maybe we should at least give them some 1-to-1 and try to really push for edibles or sublinguals. So it's we need to take this topic from prohibition and from it's bad because I don't know anything about it, to what it deserves. It deserves its own field of study. It deserves a deep expertise. It deserves full understanding, and it deserves to understand pluses, minuses, figuring out how things apply to particular medical problems. How do they fit into recreational aspect? Because I actually disagree to say that, oh, recreational aspect is bad. No, the recreational aspect can be very profoundly beneficial. If at minimum, it means that in the states that have legalized cannabis for recreational use, we're seeing a drop in alcohol use, and we're seeing mortality drop from drunk driving and fights and accidents. And it will continue. I mean, there's no question that cannabis is a much better substitution. It's much safer. I'm not even talking about heroin. I mean, opioids, it's self-explanatory. And this is where I'm passionate now, and this is where most of my frustration comes. The entire politician group knows that the cannabis can save about 30 to 40% of all opioid deaths. That's a third. That will basically add up to minimum 20,000 lives per year, minimum, probably more. And nobody's doing anything. Nobody's putting this on agenda. Nobody's talking about it. Nobody is even willing to listen to the experts who are talking about it, because it's like, oh, no, pot cannot be good for you. Like, it just cannot be, right? Because it's pot. How can
Exactly.
This level
too hot of a topic.
This level of closed-mindedness and business as usual in the government, it will eventually go away, but unfortunately, there is a lot of lives at stake. I mean, and the bigger problem, it's not even that. The bigger problem is when you're looking at academic circles, and I'm there, right? So I'm in academia. And when you bring this topic up, it gets suppressed. And the reason it gets suppressed has nothing to do with evidence. They know evidence. I mean, I'm showing evidence in every talk. It gets suppressed because of a couple of things. And one of them, in a big way, is this whole idea, oh, it's not prescribed. So if it's not prescribed, my patient's not going to buy it. And moreover, I don't know the quality and this and that, and I don't know anything here. And so I'm going to keep prescribing opioids. And that's the problem. The problem is that, we are not realizing that as a healthcare system, we have a duty to look beyond our financial interests. We have a duty to look into what's safe and what's effective and apply. And sticking around with the status quo and feeding the pharmaceutical industry when you doing this, killing people as you work, And you know it. I mean, everybody
Mm-hmm.
understands it and they know that there's value here, but no, but
Right.
it's a topic of,
And that is the thing, is getting the medical license is almost like, the neurologist makes you feel like, okay, sure, you're made to kind of look down upon for asking for it.
right. They sort of like, oh, that, it's like, it's a status of, it's a kind of
Yeah.
a afterthought at best. And, and when you ask them specific questions, they're gonna say, I don't know. And
Right.
often it's presented as if, I don't know, because it's not working.
Right.
They're not willing to say, I don't know, but here, I'm
Right.
sending you here because this person knows.
Right.
Like, that should really be the
Right.
level of conversation, but most of the time, that's not what happens.
Oh, no, not at all. No, they just bring you, last time I got my card, it was like an online one because it was in the middle of COVID. And there was no one that they could send me to that knew anything. I asked, is there any like coach? Is there anybody that could like help me with some questions? And there's
Well,
nobody.
that's
And
shifting, right? I mean, companies like Very Hill, for example, I mean, they
yeah.
have this national system now where you can get a card and then you get a coach. So
Mhm.
things are beginning to shift. I think they will continue shifting.
Yeah, that's really good to hear.
It's still not ideal because that coach is not going to know your medical problems. It's really should be integrated within the medical field. So that coach should work closely with your neurologist, for example. But that level of integration that we have in our practice at the university, that is rare. And in Chicago at North Shore, like Leslie Mendoza Teppel's team has that at the University of Chicago at North Shore. They have the Integrative Medicine Center and they do full integrated cannabis like this.
So can someone see you if they're not where you're located? Do you have that where they can do like televisit?
We do telemedicine, sure. Okay. Yeah, we do telemedicine with most of the country.
Okay, so we'll put that on the bottom of the show notes too, how they can get a hold of you.
Sure, we can't get cards in every state. There's always work around it. We can get cards for patients now in like 11 to 12 states because we have affiliate programs. Okay. But cards are often not hard, right? You just once you have a card, then we can coach you. And we coach with the straight dispensaries, meaning we will open the website. My coach especially will go to their dispensary, will look at the menu and say, this is what we're going to do. Okay. And this is the level of work that it should be, because the patient otherwise goes to dispensary and says, well, I would like to buy something for sleep. Okay. You have no clue. Right. The front person in front of they could be an outmost experts. There are some people in dispensaries that know more than like I do. I'm not denying that. But on average, it's not good. Oh, it's a nightmare. Absolutely. I mean, I've had some excellent advice. Like I said, when in Colorado, I wish I could have taken it with me. But then coming back here, I've had very, very few times have I had a great experience. But now I have more of an idea what's working, sort of. But let's finish up because I gotta for sure. Let's go. But I do really. Yeah, for sure. Well, I have like more questions. So let's do this another time. I'd love to talk more about the kids stuff. I'd be happy to do one more. Yeah. I just want to tell you how much I appreciate what you're doing. Thank you. Because I think that's what needs to happen. We need to have people who went through their own experience, who understand on both ends what it's like to be the patient in a grinder in the midst of the thickness of it, and then find a way, come out and say, now I know what to do, and then try to teach others. Because unfortunately, waiting for us, for clinicians to do that training for public, most clinicians out there are trying to make a living, and if they're big name, then they go and make money, and they try to create programs where it's all financially driven. But I think we need a lot more grassroots the way Thank you. Well, Dr. Kogan, again, I mean, thank you for that book. If you've not read it, it's medical marijuana, and it's so
I've gone over it again and again and again. It's so explanatory about how you explain the different cannabinoids and how they affect all sorts of things for different pains and how you go slow and the different mantras. I think you're going to really enjoy it. So if you haven't got it, it's an audio. If you've got eye issues, or just go ahead and order it on Amazon. So thank you so much for today. Enjoy. And again, I'm going to sign off. So again, thank you so much and enjoy. Have a great day.